what's going on. Today, we are going to learn about relapse refractory diffuse large B-cell lymphoma. It's been very
You muted yourself, Bethana.
okay. Today is a pleasure to have the fourth ILROG webinar, and we'll talk about diffuse large B-cell lymphoma. And the reason diffuse large B-cell lymphoma is on our mind right now, because there is an improvement in the outcome for those patients, which is very exciting. They have many options. And at the same time, radiation has found a way to help these patients. So first, Dr. Greg Sartre, who honored us today by joining the ILROG webinar and presenting on relapse refractory diffuse large B-cell lymphoma. He will take us through the journey of where we stand today. After that, Dr. Timothy Robinson will take it from there and see how we can fit radiation therapy in the world of diffuse large B-cell lymphoma. Dr. Greg Sartre will start first. He's an associate professor at Memorial Sloan Kettering Cancer Center. He is a clinical director of adult BMT service. He chairs the Tri-State Transplant Consortium. He's a co-chair for Lymphoma Working Group, the Center of International Blood and Marrow Transplant Research. He's very much involved in the transplant and the critical care of our patients with diffuse large B-cell lymphoma. Without further ado, we are honored and happy to have our guest, Dr. Greg Sartre. Please take it from here.
Thank you. Thank you, Dr. Dabaja and Dr. Yahalam, for extending me the invite. I like talking about relapse refractory large cell lymphoma. You could see my slide and slideshow presentation? Yep. Okay,
yes, we can.
Great. So I'm going to go through the journey of relapse and primary refractory large cell lymphoma. We consider those in the same category, essentially. By way of history and what's really happened over the last 3 to 5 years. So by way of background, the largest single medical intervention for diffuse large B-cell lymphoma was the integration of rituximab into the CHOP-like primary induction regimens. And here is the GILA study that was really the impetus behind the FDA approval of the drug over 20 years ago. You can see clear survival benefit for upfront treatment of upfront treatment of newly diagnosed diffuse large B-cell lymphoma. I do want you to appreciate where the Kaplan-Meier curves sit here in terms of more recent contemporary studies to improve upon this. The most recent large contemporary study was looking at dose-adjusted EPOCH-R, which was a more intensive regimen developed at the National Institute of Health here in the United States versus R-CHOP in a random assignment phase 3 study for upfront treatment of large cell lymphoma. This is the CALGB Alliance 5303, recently reported and published. I like to show this study because of the excellent results of both groups of patients in the random assignment. Relative to the GILA study, and there have been previous randomized phase 3s with R-CHOP-like chemotherapy and the addition of drugs such as lenalidomide, bortezomib, and ibrutinib that essentially were negative. And really the assessment of myself as well as many of the investigators is that we are probably selecting too good of patients for these randomized studies, because you can see here that both groups did exceedingly well. And I think that's important to put in light to a retrospective data set, the impressive registry that comes out of the Mayo Clinic and the University of Iowa, looking at time to treatment in practice for new diagnosed large cell lymphoma and event-free survival and impact on outcomes. Yep. Sorry, that sounded like Aki.
No, don't worry about it.
Okay.
We muted that person.
Okay. So as you can see, somewhat, knee-jerk counterintuitive is that the longer patients wait for treatment, the better they do. And this is likely, and this was confirmed with the ELISA data set from France, confirming that we are likely selecting patients following pathology review for these clinical trials and selecting good patients and not being able to answer the question if any of these interventions in a randomized phase 3 can improve upon rituximab plus CHOP chemotherapy. Now, in the relapse refractory setting, it's been over 25 years ago that the Parma study originally reported in 1995 in the New England Journal of Medicine, a random assignment study that was designed in Parma, France, with the most common platinum-containing salvage program at that time in Europe, DHAP, which is cytarabine and cisplatin-containing platinum. And patients that were chemotherapy sensitive were then randomized between 4 additional cycles following 2 cycles, or high-dose chemotherapy followed by autologous bone marrow infusion. This is before GCSF, so these were actual bone marrow transplants. And clearly there was a survival benefit in this relatively small randomized phase 3 study, just over 100 subjects. Most notably in the transplant arm, 10% of the patients actually succumbed to treatment-related or transplant-related mortality, again in the pre-GCSF era, likely secondary to cytopenic nadir and infectious complications. But clearly there was a survival benefit in the transplant group. This has established the standard of care. So the way that we like to think about relapse refractory large cell lymphoma is the salvage chemotherapy program plus or minus radiotherapy, conditioning and interventions around the transplant, and whether there's a role for maintenance or adjunctive therapy following the transplant to improve upon outcomes. So what is the best combination chemotherapy in the salvage setting? So the ICE program in combination with rituximab was developed here at Memorial Sloan Kettering in the 1990s, originally for aggressive lymphomas, including Hodgkin lymphoma and diffuse large B-cell lymphoma. And the most common regimen in Europe and most of the rest of the world was RDHAP. So the CORAL study was intended to study these 2 programs in a random assignment fashion. So basically relapse refractory large cell patients that would be deemed to be transplant eligible, i.e. less than 65 years old. As you can see, greater than 400 patients were randomly assigned between RICE and RDHAP. For patients that achieved a chemotherapy-sensitive response, as demonstrated by partial or complete response, the patients then proceeded to high-dose chemotherapy and autologous stem cell transplant or rescue. And then there was a secondary randomization of patients that proceeded to transplant, looking at rituximab maintenance versus observation only. What we learned from this large randomized study, the largest randomized study in the setting to date, as of that date, was that patients that were prior exposed to rituximab, interestingly in the CORAL study, 1/3 of the patients did not have rituximab with their initial induction therapy, as well as a high secondary age-adjusted IPI of 2 or 3, and relapse within 12 months of diagnosis, or refractory disease that did not respond to induction. Those were the 3 factors that came out. Towards the primary endpoint, there was no difference in the overall response rate between the 2 programs, and RDHAP proved to be somewhat more toxic in terms of cytopenic nadir, transfusion requirement, as well as renal injury secondary to cisplatin compared to carboplatin. But really, most importantly, from this study, we learned that patients in the contemporary era that were previously exposed to rituximab, only about half the patients actually proceed to transplant. A second large randomized study was conducted in Canada. This is the NCIC LY12, looking at RDHAP versus an outpatient program, which is gemcitabine-based GDP in random assignment. This included all aggressive histology non-Hodgkin lymphomas, but the vast majority were diffuse large B-cell lymphoma. As you could see, it was even a larger study than the CORAL study at over 600 subjects. Here's the consort diagram, and this was reported in JCO a number of years ago. What I like to highlight is that less than 50% of the patients were actually able to proceed to high-dose chemotherapy because they were deemed refractory. So 45% of the patients, by intention to treat, actually responded to the 2 programs, and there was absolutely no difference. You can't even get a pointer through these curves. So this basically told us that in terms of what's the best salvage regimen, all the platinum-containing programs are likely the same. So we would consider our DHAP, our ICE, and our GDP the same, and this was the standard of care that were eligible for randomization in the CAR studies that I will allude to later. So really, they're all the same. What about switching out the monoclonal antibody? So here at MSKCC, we were a part of a large random assignment multi-center study looking at ofatumumab in replacement of rituximab as the CD20 monoclonal antibody. Here's the study design, which is relatively standard. Here's the Orchard flow. Again, over 400 patients randomized, very similar to the Coral study, just looking at a different monoclonal antibody and ofatumumab versus our chemo. And here's the consort diagram. Sadly, as you can see, of over 200 subjects in each arm that were randomized, less than 100 proceeded to auto transplant. So as you can surmise, these are very sobering outcomes. And importantly, towards the primary endpoint of the study, no difference between rituximab plus salvage chemotherapy versus ofatumumab. So clearly the bar has been set quite low in this setting. Here at MSK, we embarked on a CTEP-sponsored study looking at the BTK inhibitor, Bruton's tyrosine kinase inhibitor, ibrutinib, in combination with rice to try to improve response rates in the salvage setting. This was a phase 1 study with dose escalation of the ibrutinib, as you can see in the lower left-hand corner. Again, a very similar design with standard 3 cycles of salvage chemotherapy, interim restaging with the CT to demonstrate no lack of progression. And then for patients that completed the 3 cycles of therapy on the phase 1, consolidation was per the investigator, with transplant eligible patients being an eligibility criteria for the study. Here are the characteristics of the study, and this has subsequently been reported in blood. 21 patients were enrolled on study. You could see that most of the patients were primary refractory or had relapsed less than 12 months. The majority of patients had high or advanced stage disease. And then we separated by cell of origin as well as histology the different subtypes of large cell lymphoma below. Here's the event-free, progression-free, and overall survivals by intention to treat on study, as well as the PFS and OS in the transplanted patients. This has subsequently been published in Blood in 2018. What we've demonstrated and other groups have demonstrated is that patients proceeding to autologous transplant, the most important prognostic factor is depth of response by PET restaging. If you exclude our study in the right lower corner, all the other studies with previous PET restaging criteria demonstrated clear benefit. The difference with our study is that we used modern ICML DOVO responses for patients that proceeded to transplant at our center over a period of 10 years. This was reported a number of years ago. And as you can see, that patients that achieved a complete metabolic response to salvage therapy and proceeded to transplant, the vast majority are cured with this modality. Interestingly, from our end, is that at our center, patients that achieved a partial remission with DOVEL4 by PET scan, which is uptake at sites of disease just above the liver, that nearly half the patients were still cured. With these data from our center, this was taken to the CIBMTR level and recapitulation of DOVEL score 4 proceeding to high dose therapy, that a sizable fraction of patients are still cured, but approximately half the patients have relapse disease following this curative intent transplant in the second line. So to recap in terms of our paradigm here, we have tried to make improvements upon the salvage therapy. Obviously, one of the major hurdles is to get patients to transplant. Our CTEP study demonstrated 100% complete response rate in non-germinal center phenotype, not surprisingly, given the activity of ibrutinib in that cell of origin. The acalabrutinib rice study was planned and is actually being opened at multiple centers to try to confirm this response to Bruton's tyrosine kinase inhibitor in combination with rice. In terms of the actual transplant and conditioning, there was one large BMT clinical trial network study, 0401, that initiated in 2004, looking at radioimmunotherapy in combination with beam chemotherapy as part of the conditioning for autologous transplant versus rituximab and beam alone. And as you can see here, this randomized phase 3 study was negative. We've retrospectively looked at, as well as other groups, the impact of stem cell dose at the time of transplant and prognostication towards outcomes. And as you can see here, we had somewhat of a separation of the curves in terms of what cell dose was infused to the patients. We also took a peek in the Center for International Blood and Marrow Transplant Registry, and there appeared to be some semblance of a signal towards improvement in progression-free and overall survival with greater stem cell doses. Obviously, these data are highly confounded in retrospect based on the number of cells collected. So we would hypothesize that in retrospect that the more we collect is the more we give, so better patients probably have more stem cells. So we're actually intending to try to answer this question at MSK with a multi-center, large, randomized phase 2 study looking at a progression-free survival endpoint in patients that are hypermobilized to greater than 6 million stem cells, and then randomized between a standard dose median, which is 3.5 to 4 million stem cells per kilogram at our center, versus the higher stem cell dose to try to answer this in a prospective randomized fashion. There are a lot of key secondary endpoints that we want to look at, including symptom inventory, patient-reported outcomes, et cetera. This is ongoing, and hopefully we'll be wrapping up shortly. Encouragingly, the Center of Princess Margaret also confirmed some other prognostic factors for patients proceeding to transplantation, particularly around this Deauville 4 partial response category. Here are their data from a large retrospective data set, again, looking at Deauville score 1 through 3 proceeding to transplant, clearly a patient group that has a relatively high chance of curative potential. The Deauville 4 group, again, sits around the 40 to 50% mark. And then of the small patients that actually had what we would consider Deauville 5, they did quite poorly with high-dose chemotherapy and stem cell transplant. I think importantly, they were able to tease out low and high or high intermediate secondary age-adjusted IPI, which is a model that was modeled here at MSK in the early 2000s, to be able to determine who in the Deauville 4 category are likely to do better. And I think this is useful in practice in terms of whether or not patients are going to be consolidated with high-dose chemotherapy, whether there's a role for radiation therapy before the transplant, or whether patients should go down the CAR-modified T-cell route. And again, I'll get into that shortly. So again, going back to our paradigm, these are the investigations that we've conducted here in terms of these buckets in trying to improve the outcomes of these patients that are proceeding to transplant or intending to proceed to transplant. I would be remiss not to mention data that were created here at MSKCC. Dr. Hoppy, who I believe I saw on the call, in conjunction with Dr. Yahal, I'm looking at patients that were proceeding to transplant with large cell lymphoma and the role of involved field or involved site radiotherapy prior to the transplant, which has been within our practice here at MSKCC. As you can see here, the group that was studied did relatively well. There are differences between the IFRT group and the patients that did not receive IFRT. Most notably, and not surprisingly, patients that did not receive IFRT had advanced stage disease, were more likely to have a high LDH, poor performance status, and elevated secondary age-adjusted IPI. All that being said, I think these data informed our practice quite well in patients with portalizable disease or disease that exists within one port that do not clear their PET scan to the level of what I would consider a complete metabolic remission. For this study, it was SUV max of 3, which is typically around liver uptake. And you could see that for patients that proceeded to transplant with prior IFRT, there appeared to be measurable benefit as reported by Dr. Hoppy over 10 years ago. Additionally exciting, Joanna Yang, who I also believe is on the call doing a quick survey, in collaboration with myself, one of our junior investigators, Mike Scordo on the transplant service, and of course, Aki, looking at patients that are unable to achieve even a partial remission to salvage chemotherapy, yet proceeded to autologous transplant following involved site or involved field radiotherapy. So these are largely patients that really did not have a response to involved field radiotherapy. This is the pre-CAR era that we decided in practice to radiate typically single fraction. And you can see the median RT dose hovering around 40 gray, and then proceed to the high dose chemotherapy. And these are the patient characteristics. Many of the patients obviously are large chest masses with primary mediastinal large cell lymphoma. We separated by secondary age-adjusted IPI, again, as a model created here at MSKCC. And then you can see none of the patients had a complete or partial remission. We just wanted to look explicitly at this group. Thankfully, these data are under revision at bone marrow transplant, but as you can see, for patients that had a low secondary age-adjusted IPI, received radiotherapy and did not progress outside the field proceeding to autologous transplant in the curve on the lower left, they appeared to derive benefit from this approach. So this really does challenge the model that patients that are completely chemotherapy insensitive can't proceed to high-dose chemotherapy, and we've actually used these data often in practice. I currently have 2 patients that we are taking down this route with, again, a low secondary age-adjusted IPI of 0 to 1. And we would demonstrate response to the involved field radiotherapy prior to proceeding to autologous transplant. In the adjunctive maintenance setting, again, going back to the CORAL study, there was a second randomization for the patients that proceeded to transplant. As you can see here, the patients that received rituximab maintenance versus observation, there was no benefit. So there's really no role for post-transplant rituximab therapy. We like to think of the high-dose therapy as a potential placement or platform for immunotherapy in the future, and whether or not that could be adoptive cell therapy following high-dose chemotherapy is an active mode of investigation currently. Again, going back to the paradigm, so these are some of the efforts that we've had in the 3 buckets. I haven't presented data, but we did do a study, a phase 1 study of dose escalation of a 1928 zeta CAR modified T cell. This was reported in blood in 2019 of 15 very high-risk patients that you can see in reference here. Currently, there is a cooperative group study looking at ibrutinib maintenance versus observation, specifically a non-germinal center cell of origin phenotype that is ongoing at the Alliance Cooperative Group as well as within the BMT-CTN. So on to the new modalities of therapy, and within the lymphoma realm, you would have to be living under a rock if you haven't heard of the 3 products that were approved in the relapse refractory setting following at least 2 lines of therapy. Those are axicabtagene ciloleucel or Yescarta, tisagen lechlucil or Kymriah, and most recently lisocabtagene maraleucel or Brezania. And then as point of reference, I have the curves of the patients that proceeded to transplant on the CORAL study up in the upper right-hand corner. So this is really the paradigm question at this time. Clearly, once products became approved, in the United States, we reckon that many of the partial remission patients, which can be quite a subjective delineation in practice, began to proceed down a CAR-modified T-cell route, given the sobering data with the salvage therapy and autologous transplant that we've known about for 20 years. So that's reflected in CIBMTR data here. So CAR T-cell in 2021, they're all directed against CD19. There are 3 FDA-approved products. We are now trying to determine who are destined to have this therapy fail them. There are also other agents approved in the relapse refractory setting in large cell lymphoma, and at least in the realm that we're living in is whether or how to bridge these therapies or sequence these therapies. Is CAR T-cell the last therapy? And some of the considerations, including radiation therapy. So just quickly going through the 3 products that have been approved. This is axicabtagene ciloleucel that was approved in 2017. It's a product that has a CD28 costimulatory molecule. This is the ZUMA-1 study. 111 subjects were enrolled. Most of the patients proceeded to axi-cell. Of note for eligibility, the vast majority of patients had 2 prior lines of therapy, including about a quarter of the patients that had a previous autologous transplant. Very encouraging results in the combined cohorts with a CR rate that exceeded 50%. For maximal response following CAR-modified T cells, you could see the duration of response here that was originally reported in 2017. There have been subsequent publications from Dr. Nilapu, most notably, I believe, in 2020 or 2019 in Lancet Oncology, with long-term follow-up data showing that it does have curative potential. And here is that publication. So you can see that there is a flattening of the curve. There are a fraction of patients that can actually be cured with this therapy. In the real world setting, it's likely 1 out of 3. Covariates that were examined within this setting, none of them came out, including IPI, external sites, as well as bulky disease. Subsequent analysis have revealed that tumor bulk as measured by SPD or LDH. These are data reported by Fred Locke in conjunction with investigators from Kite sponsorship, that likely LDH, or I'm sorry, likely tumor volume is a prognostic factor within this disease. The Juliet study is the phase 2 study of tisagenlecleucel or Kymriah. This was the second product that was approved. Of note, a different co-stimulatory molecule, which results in lower risks of toxicity, including cytokine release syndrome and ICANS. Here are the Kaplan-Meier curves that were reported. Patients that achieved a complete response, as you can see, similar to axi-cel, that the majority of patients that achieve a complete response to this therapy appear to be cured. Again, covariate analysis variables did not come out to be prognostic, at least in the prospective phase 2. Notably, there appears to be a signal in terms of baseline tumor volume, again, as measured by some of the perpendicular diameters, or SPD, on cross-sectional imaging. I think a poignant abstract that was presented at ASH based off this study was looking at LDH as a measure of tumor volume. And clearly this speaks to selection on clinical trials, because for patients that had a elevated or very elevated LDH as measured by 2 times upper limit of normal, clearly those patients unfortunately were destined to fail this therapy. The third product that was recently approved is lisocabtagene maraleucel. This is a product from BMS, formerly Juno. As you can see here, very similar Kaplan-Meier curves based on response. Importantly, in covariate analysis, it looks like tumor bulk or tumor volume, again, appears to be prognostic, with lower volume patients doing better. That's also measured by LDH. So really the state of the science right now, as one could surmise, is given the sobering data of platinum-based salvage followed by auto transplant, is in the second line for relapsed refractory patients being randomly assigned between CAR T cells and standard therapy, standard therapy being platinum-based salvage of choice, again, believing that they're all the same, and then patients with the ability to cross over. This ZUBA-7 study was the first to complete, and it has been reported in press release as positive towards the primary endpoint, which is an event-free survival endpoint. We will see the data at ASH. The Transform study, very similar, but this is with lisocabtagene maraleucel. These designs are all very similar. Again, recent press release, positive for event-free survival. Again, we're awaiting data to be presented at ASH. And interestingly, the third study, the Belinda study, which is tisagenlecleucel versus standard of care platinum-based salvage followed by auto transplant, most recently was reported, again, in a press release without data, to be negative towards the primary endpoint. So we await that at ASH. Some of the questions with CAR-modified T cells, whether patients can be consolidated in CR. Some patients achieve a complete remission to bridging therapy. I'm going to kind of speed up here to give the other speaker some time, but basically based off the Juliet study, which is tisagenlecleucel, there was a number of patients that achieved a CR to bridging therapy, and patients that were reinfused with their CAR-modified T cell product appeared in a very small subset to enjoy long-term complete remissions. This has subsequently been published. Some considerations of practice is if a patient fails CAR T cells, and based on the data, the majority still do, is this their last chance of cure? This has been well described at the Fred Hutchinson, and patients with early progression of disease, clearly those patients are destined for poor prognosis, but for later progression outside of a month from the time of CAR T cell, that some of these patients are able to be salvaged. What we do deal with following CAR-modified T cells is a high incidence of cytopenias, including neutropenia and thrombocytopenia. This is reported data from an Israeli group looking at the depth and duration of some of these cytopenias, which we have encountered in practice and can be long-lasting. We have also reported similar data in terms of grade of cytopenia from time of CAR-modified T cell. You can see month 1, month 2, month 3, but there is a progression of recovery of hematopoiesis. The real trouble is when patients have deep cytopenias and have progression of disease. So it's kind of the worst of both worlds. I like to highlight the maximal response of a partial response. Most of the patients are failed to or destined to progress, and the role of allogeneic transplant in patients that have some form of a therapy-sensitive remission in registry data on the right is still a viable option. I think this is a viable clinical question. Of course, in random assignment studies, allotransplant is tended away from because of the risk of non-relapse or treatment-related mortality. Briefly, some recent FDA-approved products, again, following 2 lines of therapy, includes CD19-directed therapy. Tafasitamab lenalidomide has recently been approved, as well as the antibody-drug conjugate against CD19, loncastuximab tesirine. And you can see the encouraging curves here. There appears with short follow-up to be somewhat of a plateau. Longer follow-up will need to be determined. 2 additional non-CD19 target agents were recently approved, including bendamustine and rituximab with polatuzumab, as well as selinexor. You can see the response rates here. I do like to highlight the Kaplan-Meier curve with BR-POLA. There does not appear to be a durable plateau. So we often, given that it does not target CD19 and risk for antigen escape or antigen masking, will use this agent in the bridging while patients' CAR-modified T cells are being generated. So in conclusion, in first relapse large cell lymphoma until December of 2021, when we actually see data, the standard of care remains platinum-based salvage therapy and high-dose therapy followed by stem cell transplant in patients that achieve at least a chemotherapy-sensitive remission. There might be a paradigm shift, and we're going to anxiously await these data in the next few months. Chemotherapy insensitive to platinum, there are many different options, mostly centered around CAR-modified T cells. The way that we do like to bridge therapy is to avoid CD19 directed therapy if the CAR T cell is planned, reserve therapies such as loncastuximab as well as tafasitamab lenalidomide for after CAR modified T cells. Allo-HCT as a transplanter is still an available option in sensitive disease and does cure a fraction of patients, around 40 to 50% in patients that actually proceed in some form of remission. So with that, I'll wrap up and I guess happy to take questions at the end.
Thank you so much. That was fantastic. We learned a lot in the past 35 minutes. That was a great round of
You muted yourself.
There you go.
Yeah. Okay. Thank you so much again. I think we have 2 questions. We'll go ahead with it since you are our guest. The first question that I'm going to ask you is twofold. The first one is, when you go through the high-dose chemotherapy in the background of a CAR T cell and the pancytopenia or the reduced cells that you're seeing in the marrow, are you finding that it's going to become challenging to collect these patients? And that's question number 1. Question number 2 would be, where do you envision we will be 5 years from today, and how are you going to combine CAR T with the high-dose therapy? Would you envision that these would be together, used sequentially, or one would eliminate the other?
So to the second point first, we are anxiously awaiting to see the data on these studies because there was a bit of subjectivity in terms of patient flow based on therapy sensitivity in the non-investigational arms. And it was an event-free survival endpoint. So the follow-up is going to be short. What we do know is that it is, or what I would speculate is it's going to be very difficult if CAR T cells are approved in the second line to then salvage those patients with platinum-based salvage and autologous transplant based on the cytopenias and the injury to the marrow. To answer your first question, in the era of plerixafor or Mozobil, which is a secondary CXCR4 inhibitor for mobilization, rarely patients fail collection in the second line. So that's been a real revolutionary drug because historically up to 15% of patients fail to collect stem cells.
Okay, that's great. Dr. Plasteras had a question and Dr. Hoppy has a question. Feel free to unmute yourself and ask it, or if you like me to read it. John, do you want to ask your question?
Yeah, I can kind of summarize. I think all of us on this call as radiation oncologists, see a lot of patients for initial consolidation. So they've had their chemo and we have, should we consolidate? Should we not consolidate? Is it bulky? Is it not? There's 1,000 reasons why we might consolidate. And it usually comes down to, well, radiation, we think, can provide a local control or a progression-free or relapse-free survival benefit, but the survival benefit's always the question mark, right? And this all comes down to, well, but we can salvage you if you do relapse, so maybe we don't need to use radiation. But I think one of the things that's interesting, people tend to take the number of successes from the transplanted patients and say, oh, well, these are what our results are when you get an auto transplant in the salvage setting, and so we can salvage a lot of patients. But my mentor, and I guess the mentor of other people on the call, is Eli Gladstein, who always would scream and yell about how the transplanters love to gerrymander the denominator. And so he would go ballistic whenever people would present transplant data, because they didn't talk about the people who relapsed and then went into salvage and then didn't get a response, and then you never saw those people in the transplant literature. And so I just wanted to get your thoughts as a medical oncologist on how we should be talking to our patients about what the prognosis is for salvage and so forth, and what's the value of getting those, local control, progression-free survival values better, given that maybe the salvage situation is a moving target and not always as rosy a picture as the curves might look like. Does that make sense?
I think so. I think I know what you're getting at. I am going to use gerrymandering the denominator because that's great. In transplant, we see what we catch. We rarely are able to define the denominator. I have the fortune of having a foot within the DMT of lymphoma here with Aki and the group, so we are able to make these decisions collectively. So I think that you're in a similar situation. You see what you catch, or and it really, I personally, I think it emphasizes that it really does need to be a multidisciplinary disease management decision. Because there's a lot of ways to parse these data. We've always struggled because we've had such a strong relationship with radiation therapy over 3+ decades. How would these patients do if we did or did not radiate them prior to further consolidation? As you all are aware, we're somewhat unique in using involved site or involved field radiotherapy prior to the high dose therapy, where a lot of the rest of the world does it post. And we've tried to design retrospective analyses with other centers, and it's always difficult because, again, gerrymandered denominator and who makes it to that time point. But I think your points are excellent. I think it's all going to change, or I'm smelling a paradigm shift here, and the next realm of investigation is how we all work together in the likely more than half the patients that are going to fail CAR T cell in the second line.
Thank you, Dr. Sartre.
I can forego my question so that we can,
go ahead.
I can forego it so we can move on.
No, you can go ahead and ask it because we want to analyze the. Yeah, go ahead.
Yeah, no, the randomized trials are very interesting to me regarding stem cell transplant versus CAR T. And I'm just wondering, you showed some promising results for transplant in the Deauville 4 patients. And I'm wondering if patients having an incomplete response to Deauville 4 on those trials are actually considered an event.
So you hit the nail on the head that we have to see, because they have subtle differences between the three. Many of us thought that the real study should have been patients with the Deauville 4 being randomized between getting the transplant and going to a CAR T cell. So that water is going to be mucked up with the patients that have brisk responses, as well as those that have rapid progression. So I really want to see how the data play out.
Okay, we're going to move on to our next speaker, Dr. Timothy Robinson. He's an assistant professor at the Moffitt Cancer Center at the University of South Florida, and he's the section head for malignant hematology and cellular therapeutics. He will give us his take on the role of radiation in relapsed refractory diffuse large B-cell lymphoma, and stay tuned for the end. We're going to have a discussion with both the speakers and those of you who are on the call. I know many of you it's late at night for you, and we really appreciate that you're hanging on. Thank you. Go ahead, Dr. Robinson. Thank you for joining us.
Yeah, thank you so much. Can you see my slides? Okay, wonderful. Good. Thank you so much all for inviting me today. It's a real pleasure and honor to be talking here today. So today I'm going to talk about the role of radiation, relapse refractory diffuse large B-cell lymphoma, focusing on kind of the CAR T setting. Craig did a phenomenal job talking about transplant, and this is kind of going into the CAR T radiation realm. So spoiler alert, again, just in case people are busy and just to make sure we get the take-home points. So first spoiler alert is that when folks go to CAR talking about, kind of the selection bias we talked about and the kind of gerrymandering, there's often a 2 to 3 month delay from the time that a patient is identified as a potential CAR T candidate until they actually get CAR T infusion. And you're talking about relapse refractory diffuse large B-cell lymphomas, at least 2 lines of refractory therapy, often many more. And these are often fast growing, aggressive, often symptomatic, and sometimes even fatal during the delay. And so bridging radiation therapy, perhaps best after apheresis, as a question mark, is basically it's a safe and effective means of getting patients to CAR T, particularly with those with bulky, symptomatic, well-localized, or chemorefractory tumors. And I think that's kind of this is becoming a more and more agreed upon point. There has been no evidence of radiation-induced excess toxicity. However, I would recommend that we exercise caution, particularly in 2 settings. One, with large volume treatment fields in patients with existing severe cytopenias. So the issue of severe cytopenias is a big one, and we don't fully understand the interaction between radiation and those cytopenias. Radiation by itself in a patient who has no issues with cytopenias, those patients will bounce right back, but there's some kind of synergy between the 2 that we don't fully understand. And then 2, radiation pneumonitis. Again, just anecdotally, folks who have had the kind of chemotherapy that lymphoma patients have had, our kind of standard Quantec normal tissue toxicity curves don't really apply directly to those patients because they're a lot more sensitive to the radiation doses that we give. And so I think that's something we just need to keep an eye on going forward. Number 2 is that the patterns of failure with relapse refractory lymphoma after CAR T appear to be predominantly localized. So we actually have seen up to 1/3 of patients are having kind of purely local failures, meaning that they're failing just at the sites of disease they already had, and that's the only place they're failing. And so this is kind of a very interesting finding because, again, we think of diffuse large B-cell lymphoma as a diffuse kind of systemic disease. Also, the response to CAR T is highly heterogeneous. Even in patients who ultimately succumb to disease, vast majority, 80%, 86% of them plus, actually have one or more of the disease spots actually resolve, go away, or at least temporarily go away. So it's not an all or none response, very heterogeneous. And then salvage radiation for earlier kind of localized disease has been associated with excellent outcomes from work out of Sloan Kettering. And I think that's also another place where we should really think about this. And then lastly, focal radiation may improve outcomes in these folks, especially if they have high burden or bulky disease, but that's unproven. And so that's kind of the future, question of where we're trying to take things is, sure, we can, salvage folks, sure, we can shrink down tumors, we can alleviate symptoms, we can help people get to CAR T, but, is there a way we can just try and improve outcomes overall, like we've been talking about? And I think there's really 2 kind of, the treatment volume, the dose, these are all subject to debate, but really there's 2 kind of models. These are kind of priming immunostimulatory model, low doses, maybe a single lesion. And then you have the more ablative high doses, treat all the spots, kind of a teaser, Ash will be talking about some of our kind of experience leaning us towards the ablative side, but Dr. Sim. And I think that it's going to be really important to have diverse prospective trials in order to basically come up with a clear conceptual model and test these different models so that we don't miss an opportunity to figure out how to do this. Also, Dr. Sim needs a job, preferably near Ohio. He's one of our graduate radiation residents who's done a lot of this work, really made it happen, and has done a phenomenal job. So just a very brief kind of case report to give you an idea of the kind of patients we're dealing with. 73-year-old male, stage 2A diffuse large B-cell, basically had a large left glial mass. He got treated with R-CHOP ×6, complete response, came back 6 months later. RICE ×3, complete response, beam, autologous transplant for consolidation, 6 months, came back. Got focal radiation, 6 months, had a marginal recurrence. Got focal radiation, 8 months, had marginal recurrence. Got rituximab, Revlimid, 8 months, had a recurrence, clinical trial, and then ultimately taken off that trial. And then actually the disease progressed to the point that patient had compartment syndrome, emergent fasciotomy, and actually had above the knee amputation due to extensive muscle necrosis. Patient was treated in North Dakota and basically was referred to Moffitt. This is back in 2018. I think the number of centers doing this was more limited then. And really it was about 2 months later after the amputation that he got to see BMT here. There's progressive disease, took 2.5 weeks for clearance and workup, and basically started cyclophosphamide and dexamethasone as one bridging chemo, and then I was referred to radiation oncology as well. Just an example PET, so again, very aggressive disease encompassing basically all the soft tissue in the muscle, and we basically just treated large volume 20 gray and 5 fractions, APPA, concurrent chemotherapy. And that patient did well. So they had a complete response, and they're now basically 3 years out from treatment, and they are basically touring the country espousing the values of CAR T. So, just kind of some of the key points here is that with these patients is that even, when we know about it, there's 3.5 months from the time the patient had a very tragic, a very clear sign of evidence that the disease was out of control to the time that they got the CAR T infusion. Even after they reached this, it was a 1.5 months between even just a very timely workup and getting to the actual infusion. So a 1.5 months even after they saw someplace that can do CAR T. 6 lines of prior therapy is not at all unusual, and 2 rounds of radiation with marginal missiles. So again, I want to illustrate this point that this patient had tons of treatment, blowed through all sorts of stuff, very bad disease, still no reason to count them out necessarily. Practical considerations: treatment's expensive, requires prior authorization, potential severe toxicity, so they have to have eval, and then after they're cleared 3 to 4 weeks for workup before they can get the actual infusion of the product. So the first thing when this came up, that's how this first started. Is we basically had patients with kind of just man-eating tumors that were just out of control. Patients were just trying to make it to CAR T, and so that's how this we kind of initially got involved. And it's interesting because before I came to Moffitt, I honestly, back when I was on the job market 7-8 years ago, I wasn't even familiar with Moffitt, so I came here. But the interesting thing is that Moffitt actually has a bit of a legacy in the immune therapy world because it's located. It was the only NCI designated cancer center in Florida, which is full of older folks with light skin who like sun, and so melanoma and cutaneous disease is just off the charts here in Florida. So it's kind of the Australia of America. And as ipilimumab was the first checkpoint inhibitor that showed promise back in 2011. And so Moffitt's kind of really been into immune oncology, long before it was kind of, the cool thing to do, and we all became immune enthusiasts. And so Dr. Fred Locke was mentioned in the previous discussion. So he's been a leader in a lot of these trials, and actually the first patient enrolled on clinical trial for CAR T was done at Moffitt. The first patient treated with commercial insurance for CAR T was at Moffitt. And so it's just really, really wonderful having these folks to collaborate with and just trying to learn how to treat these patients better. And so that's how this all started. How do we just get these patients with large tumors to CAR T? And basically, when we look at this, just the initial 12 patients, and we didn't know what we were doing. We're all over the map. 12 gray, 6 gray, 30 gray, 36 gray. So really, just no real idea of what we were doing, but just trying to get patients, to CAR T, and sometimes using more of a priming dose, sometimes more of a treating dose. But really the take-home points is that there's no significant toxicity that we saw, so it's safe. And I've since talked to other folks at leading centers, academic medical centers, who told me they've seen patients, they refer to patient with, for CAR T referral, big mass, and they kind of, to paraphrase, were kind of chickened out or too concerned about doing radiation because they're worried about toxicity or some, issue. And I think that's a real lost opportunity. And so again, I think the risk of toxicity is not, high for these patients. Also, in the short term, patients did well. So that was the initial experience. We were thrilled that we didn't kill anybody, nothing awful happened. So that was a plus. And so that was our experience. And of course, UPenn, John Plasteris and Chris Wright published this. So our Moffitt's basically an axicell shop. They expanded this to Tisacell, and they saw the same thing. And more importantly, there's a Plasterian, title play on words with CAR. Editorial about the first paper: don't get stuck on the shoulder. Radiation oncologists should get into the CAR with T-cell therapies. So that's always fun. One thing that has come up from fellow collaborators and medical oncologists is we've had patients discuss in tumor board, and we said, well, is this a role for bridging therapy? And they said, well, I heard that bridging radiation therapy is associated with worse outcomes. So. And they typically in the same breath admit that there's selection bias, but still it's a concern that comes up that needs to be addressed. And so it's this lovely work out of MD Anderson. So Chelsea and McDana and friends did some wonderful work basically looking at bridging therapy for these patients. And bridging therapy, including all types of bridging therapy, chemo, radiation, all of it. And what they saw is that patients who got bridging therapy overall did worse. Okay, progression-free survival, overall survival. And this is the kind of thing that, again, just looking carefully at the data, but if people aren't careful, they get overly excited. And of course, to their credit, they were very astute about how they interpreted this. They looked very closely at it. And when they broke it down by the different types of kind of bridging radiation therapy or bridging therapy that they got, radiation alone actually did not do poorly. And they did kind of more or less comparably patients who didn't get any bridging. It was the folks who kind of had, systemic chemotherapy or combined modality. And I think, again, the issue here is it's likely selection bias. If you require chemotherapy and radiation just to get the CAR T, that's going to be a particularly aggressive tumor. Amongst folks who are getting radiation for bridging, what they saw was that comprehensive radiation folks, again, small numbers, but they actually looked like they were doing better. And so, again, this is just, I think, helping dispel the notion that somehow radiation is resulting in some, poorly understood synergistic toxicity that we really need to be scared of. Because again, if you're getting more radiation, or at least all your sites are getting irradiated, it's not getting rid of the antigens or making it impossible for the CAR T to work. That wasn't really a concern. We were always worried about, if we get rid of the tumor, will there be anything for the CAR to go attack? And I just don't, the more we look at this, I don't think there's any evidence to support that. So the interpretation of this is that patients getting bridging radiation, and other therapies have bad disease. And, as I said in their paper, concern for disease-related mortality in the period between apheresis and CAR T infusion is justified. People can die during this window if they can't make it through. And in this study, about 1 out of 6 didn't even make it to apheresis, so poor outcomes overall. So radiation monotherapy's bridging strategy was not associated with poor outcomes, and then comprehensive total radiation trended towards better. And of course, the Plasterian commentary, navigating the narrow bridge to CAR T cell therapy. So hopefully those will keep coming. All right. So take home point number 1 is that bridging patients with radiation therapy for symptomatic, rapidly growing disease so they can make it to CAR T infusion, I really think as a field, we should kind of say that's a good idea. I think that's a solid indication, and I'm not really seeing any, there's not really any leaping concerns about it. I think it's something that we should really be thinking is kind of more or less trying to adopt a standard of care. Is there a role for salvage with radiation fawn progression after CAR T? And this is wonderful work out of Sloan Kettering, Brandon Ember, and Ahe, of course. And what they did was just looking at early experience with salvage radiation. And, again, it's all small numbers because that's the nature of the beast right now. But again, I think it tells a story, is that when they did salvage radiation for patients, it was 12 patients, and the ones who had localized disease, so if they had local relapses, they actually did quite well. And so if they had local relapses with salvage radiation, the survivals were phenomenal. Whereas if it was advanced stage disease, they did much more poorly. And so this is kind of pointing to the idea that, again, if the disease appears to be acting kind of in a more locally, progressive manner, maybe there's a real opportunity here for radiation to help out. And so I think that's also, again, if you have a patient who's, relapse status post CAR T and it's relatively localized, I think that's a place where salvage RT should really be considered. So what next? So the bigger question is, can we use radiation for disease control and overall outcomes in CAR T? And this is a slide stolen from Brandon Ember during one of the previous, discussions of CAR T at our ILROG. And just really, and Craig also did a great job of just kind of talking over these different products are out there. And it really looks like about all comers is about a 40% durable response rate. And it seems to be fairly consistent across different products, clinical trials, practice in the community, plus or minus around 40%. And so, the question is that, how do we kind of figure out how to move the needle forward instead of just reacting and treating and then see how people do in describing it? And so what we're going to do is look at patterns and predictors of failures. This is work by Nick Figueroa here at Moffitt, who led this, and Austin was also part of this work. And, the problem is that most of the research, is focused on systemic mechanisms of tumor escape. So I might talk more about this later pending time, but, for acute leukemias, they found that CD19 antigen loss was an issue. For the lymphomas, Fred Locke and Mike Jane, as mentioned, the blood advances, they found that T cell exhaustion, immune suppression, chronic interferon gamma signaling. There's all these systemic markers of poor outcomes, metabolic tumor volume. But, as radiation oncologists, I think one place where we can make a contribution is thinking kind of more anatomically about how we approach this disease. And so what I wanted to do is just describe the recurrence patterns following CAR T to see kind of what was the natural history of this disease for the patients getting CAR T. And then see if we could figure out which lesions were going to fail. And so that if we knew which lesions were going to fail, maybe we could go after them. And this is inspired. So when I did my training at Duke, Chris Willa, who's still chair there, would always talk about this paper by Gunderson and Sosin. And it was this seminal paper where it's this for gastric cancer that talked about patterns of failure. And, basically as patients who got surgery for gastric cancer and they didn't get any radiation, but then they just saw what happened in the natural history. And so that was kind of the inspiration for this situation is, can we do a patterns of failure for diffuse large B-cell lymphoma? And of course, when I told Nick to take a look at this paper and it was going to be the model for how we're going to proceed, he said, "You mean the one published in 1982? And I said, "Yes, that's the one." But it was kind of inspiration for how to go about this. So CAR-T patterns of failure. So what we wanted to do is just look at all patients with disease progression who didn't get radiation, so didn't muddle the waters, and look at both the patient and lesion level to see what the outcomes were like. We had 60 patients, about 500 lesions treated over 4 years, had a year of follow-up, and we defined progressive disease at an existing lesion as a local failure. And then if it was a new spotted disease, that was considered a new or distant failure. And about 60% of patients progress, so again, consistent with kind of our observations in other settings. And only about a third of patients had only local failures. So again, this is a bit of a surprise that a third of these patients, if we had, using the retrospective scope, treated all sites of disease, could we have cured these patients or prevented progression? And 85% of them had some form of local component failure, either isolated local or both local and distant. We also saw a lot of lesion level response heterogeneity, even in patients who progress on CAR-T therapy. The vast majority of them have at least one or more sites of disease that actually will respond. And oftentimes the disease will respond and come back. When we looked at lesion level analysis, we looked at different factors. So we said, are these lesions were bigger, necrotic, defined by PET, were they clustered? Sometimes when you try to treat these patients, it's aggressive disease, it'll be nodes on top of nodes on top of nodes. And so we just call that kind of clustered. And then a higher SEV max of 10, again, just something in the literature that's been seen to be correlated with poor outcomes in other lymphoma settings. And really, they all kind of more or less showed the same thing. They're all highly correlated. And the most simple one we had was really just diameter greater than 5. So really, a single lesion greater than 5 was about a 2-fold increased risk of that lesion recurring as it was for the rest of them. Multivariable analysis said that really either the large size, high SEV max, really either of these was kind of, could be said to be driving the kind of recurrence in these patients. And just to kind of give an example, before CAR-T, you have a large tumor. 30 days after, tumor goes away, and then 3 months later, it comes back. And so again, I think this is an area where we don't want to be kind of resting our laurels of saying, oh goodness, it's 30 days out, the disease is shrunken down, I'm going to declare victory and walk away, because that's how many of these fails. They go away, but then they come back. So that doesn't mean that it's all clear. When we looked at the patient level analysis, I think one of the very interesting things is that looking at just lesions by themselves, if a patient had a single lesion that was 5 cm or larger, which is kind of on the low side for what we call bulky, but we looked at all different sizes of lesions and really found that kind of less than 2 cm were low risk, 2 to 5 cm were kind of middle, and anything over 5 was a high risk lesion. And if a patient had a single high risk lesion, that they were actually twice as likely to fail at a patient level. And so that's really nice because, again, there's a lot of different metrics out there, metabolic tumor volume. But if you've ever tried to calculate metabolic tumor volume, it requires specialized software and a lot of elbow grease and a lot of subjectivity in the software. There's variation from in how it's done. So the idea that we can just look at a lesion and see if any of them are greater than 5 cm greatly appealed to us to just try and simplify how we think about this and how we identify high-risk patients. And then similarly, we saw with necrotic lesions, if they had a single lesion that was necrotic, patient overall did poorly. And really, when we looked at these, we sliced and diced these many way. They're all highly correlated. And at the end of the day, you don't get a whole lot of more bang for your buck than just using 5 cm for a single lesion. And that includes even looking at metabolic tumor volume. It actually performs very similarly to splitting tumors by or patients by their total metabolic tumor volume. Patient level analysis, whether you did or did not have a 5 cm lesion, this is without, this is with. So it really was just a very large difference in outcomes. So the kind of part 3 spoiler alert, it's not spoiler anymore, but basically focal radiation we think may help in these patients if they have kind of a bulky as defined by 5 cm site of disease undergoing CAR-T. So it's not proven, but we know that if you've got a large lesion, that you're twice as likely to recur overall. So the overall outcomes for that patient population are going to be much poorer. And then 2, you know where it's going to be or more likely to be. And so those things together kind of makes me think that's what got us more excited about doing this, even in patients who didn't need to be bridged just to kind of survive the trend to treatment. And so that's kind of the third kind of question mark. There's details about radiation, dose, fractionation, volume, timing that we don't know. I think there's kind of some mild consensus that timing is best to do the radiation after the apheresis, because we don't want to lymphodeplete somebody or somehow cause cytopenias that then prevent apheresis and slow things down. But beyond that, there's a lot of kind of things as an ongoing moving target. So the question is, well, should we do radiation with CAR T when we don't have to, when our hand's not forced? And so the next kind of phase of what we were doing is looking at when patients that now we've really adopted bridging radiation for these patients, how has that changed the patterns of failure? What has that told us about how it changes the natural history of the disease? So we've actually about 45 patients now who've been treated with bridging radiation over the past 3 years, wide range of doses. Most commonly, we use 37.5 and 15 fractions. Again, these tend to be hypofractionated just so that you don't hold up the CAR T. You usually have 3 or 4 weeks to work with. You know, you may or may not have had a sim in time. So you really have to kind of make this happen quickly. And really what we found was that when we looked at the policy, this is embargoed, and so we'll have to wait to Astra to talk about it. But very excited about that work and kind of, telling how it's informed our practice going forward and how to kind of do this next steps. In terms of prospective trials, this is the next thing that's needed, and we're working on this. So we're basically, we have our kind of protocol put together now, and we're, actually it's, funding the BMT folks, to their credit, are funding it internally. So we're getting the kind of the trial wheels moving, and hopefully by early next year, we'll actually be able to start enrolling, famous last words. But really, we need prospective clinical trials, and we need clear conceptual models so that we can then design trials around these models and then test those ideas. Again, we have all these kind of very lofty ideas about abscopal effect and immune stimulation, but I think it's really critical we have a clear conceptual model and design the trial to test that model so that we learn something no matter what happens. And I think radiation oncology as a field will really benefit if we kind of cover our bases, if we have diverse models and approaches, so that we don't miss out on a potential to help move this field forward. So let me pause there. So Bethana, how much do I need to wrap up now? I know we're over time, but this is more philosophy. I can skim through and just get to the end, or where are we on time?
We
5
usually
minutes?
like to wrap, yeah, 5 minutes, and we have lots of questions, I'm sure, that
Okay.
are gonna come up, and we can have some discussion.
Okay, wonderful. I'll wrap it up in 5.
Okay.
So this is one really nice piece of philosophy that was in the Nature reviews about, other settings where we're trying to use radiation to improve outcomes with immune therapy. And so this is called time to abandon single site radiation for inducing abscopal effects. And really what they concluded was that there's been just tons of clinical trials where we've tried to irradiate a single site of disease with checkpoint therapy. And really there's not been a signal that single lesion kind of approach has been working. And so instead, what they advocated was maybe considering more comprehensive radiation, or radiating of all lesions. And again, so the models are radiation of single tumor site versus radiation of all tumor sites. So there's different ideas for each. And this is kind of the model that, we're leading towards, just kind of based on what we've seen in our data. Another thing that kind of pushes us towards the radiate all sites of disease as maybe being our kind of conceptual model is, this is just one of the several kind of oligometastatic trials that's been done. And so in oral, there's patients who are getting, SBRT for prostate cancer. And the interesting thing is that after they did SBRT, these patients, they were able to look in hindsight with PSMA radio tracers to see, hey, we thought we tried to treat all sites of disease, but did we get it all? Did we actually do comprehensive radiation for this patient? And what did that do to outcomes? And the really kind of remarkable thing is that, for patients who had no untreated lesions, so when they did the PMSA and they saw that, yeah, you really did get all the spots, these patients actually did quite well, especially compared to patients who had, so much as a single lesion that was missed during the radiation treatment. And so again, it's all kind of retrospective and post hoc, but it's all pointing the same direction. And so, what I would say, just kind of to put out there for some philosophy, is for the abscopal effect, or really how do we make radiation and immune therapy work together? Do we have it backwards? So I think the prevailing model is that, radiation stimulates antigen release and immune stimulation. And it's not to say that's not happening or not right, but I think the alternative model that, practically speaking, may be helpful for trials and treating patients today is, radiation ablates immunosuppressive tumors, and maybe that's what it's doing for us. And, how do we test this model? So with the current model, you would think perhaps, if there's more disease, there'd be more antigen, then better response. Alternatively, if there's more disease, that's worse because there's more potential tumors that could be immunosuppressive. And so again, and as you may know, the more disease we see, that's what we see in patients, is that they do worse. And that's true for immune therapy. That's true for, checkpoint inhibitors. That's true for CAR T. And then in the current model, if we did a single radiation of lesion, that should still help stimulate immune response. Whereas if the alternative model that we need to kind of treat all sites of disease or destroy all the immunosuppressive tumors, that's probably not beneficial. You would think that at some point, this would work if you just do radiation alone, that might stimulate immune response and cure some folks, but that's not something we really see. And again, alternative model, we don't really expect that. Analogous model is the current model is kind of more of a tumor vaccination. You make more antigen. And I think the thing I like about this model as well is the ablative model is that it's more akin to immune checkpoint therapy. So the way checkpoint therapy has made it, has worked is that it's suppressing the immune suppression. And so if we can use the radiation to neutralize the sites of immune suppression in these tumors, maybe that's a way it can make it better. And then the mechanism, of course, releasing tumor antigens. And one of the key things that my mentors, Mark Dewhurst, once told me was, he's like, Tim, hypoxia is incredibly immunosuppressive. If you put T cells in hypoxia or acid or in a lack of glucose, they will immediately shut down. And so in these tumor microenvironments, especially these large tumors, forget the clonal activity. If you have a large necrotic tumor that has all this acid and hypoxia, the T cells are going to have a really hard time fighting off tumor cells in that environment. So I think radiation has an opportunity to kind of neutralize these immunosuppressive clones or immunosuppressive, organs of immune suppression from the tumor.
Tim, I would like to, if possible, wrap it up, but also go back to the previous slide because I have a question there.
Yes.
My question to you is the following. We do talk about abscopal effect in solid tumors, but then what do you think about the fact that hematological malignancies are completely different than solid tumors when it comes to the local immunogenicity or to the presence of hypoxia in the first place? There are very few tumors that we see in hematological malignancy, no matter how large they are, that you could see that there is hypoxia. The second thing is we have proven that a lower dose of radiation, or we have proven that we can use the radiation in two forms. The one which is you want to ablate a la solid tumors, and the one that you want to use to, for example, prevent graft versus host in transplant when you use only 2-grade TBI, or the one that you use it for low-grade lymphoma to just stimulate the microenvironment. So isn't it time that we abandon the idea of abscopal effect, because that maybe one doesn't exist and two really doesn't apply to hematological malignancies, because there is a high local immunogenicity when it comes to hematological malignancies versus solid tumors?
Yeah, no, I love it. So the whole point of this was to stimulate discussion, and I knew it would. And so I think these are phenomenal questions, and I'll go ahead, if it's okay, and push the discussion to the end, because I love your questions, and that's the point of this, so to kind of get us thinking about it. But I'll go ahead and just skip ahead just to kind of get through it, and we can talk all about this. But no, I completely agree. I think there's a lot of nuances there, and it was meant to be a little blunt, just to kind of stimulate discussion. The last thing I'll make on the philosophical point is that I think it's interesting that I think several of us have been asked, hey, are you worried about losing your job as a radiation oncologist because of all this immune therapy coming on board? And I think paradoxically, we've seen the opposite. So again, I treat actually CNS as well as heme, and in the era of immune checkpoint therapy, we're seeing more and more patients because, now there's actually a chance to do something for them. And so you have more and more patients living longer from brain mets, where before they would you'd see them, treat them, palliative, go home, and they would pass away. And so I think, we're actually in this window where we're seeing more and more patients because we now have the ability to, kind of bring people back from total systemic failure, because we have, we've made progress there. And very brief 60 seconds on this, just to put it out there. One other thing on the kind of more basic science front that's not really been talked about much is in terms of how these tumors are resistant. If you look at the development of hematopoietic cell lines, actually 17% of all genes in hematopoietic cell lines are actually undergo alternative splicing or intron retention as part of their normal development and definition. So it's just how they work normally. And alternative splicing is when you have kind of a gene, it makes a function, and we can kind of mix and match different parts of the gene to make different functions. You can think about a gene being, if a gene is a bus, it's a form of transportation, but then you mix or match the parts, you take the wheels off that bus, now you've got a roadblock. And this is true, holds true for many genes. 94% of all genes in humans are alternatively spliced. So it's this whole ability to kind of have dominant and negative swing back and forth. And just of interest, we kind of panned across all different cell types. And we saw that hematopoietic malignancies, lymphoma, myeloma, ALL, AML, they really have a huge number of aberrant splicing events as part of kind of who they are. And so there's a lot of opportunity there. Collaborating with Mike and Fred, we actually have RNA-seq patients from about 30 patients who did versus did not respond to therapy. We did some detailed splicing analyses, and so there's actually a number of events with splicing that was correlating with resistance to CAR T. And the very cool thing is that one of the big things that came out are DNA damage response in terms of the gene ontology, as well as apoptosis. And the one kind of in vitro CRISPR screen of CAR T resistance that's been done was actually showed that the one pathway that came out as genes that were able to confer resistance to CAR T was apoptosis. So this kind of got us excited to think that we might be onto something. So that's future directions. We see that it also correlates with patients who do versus do not have response. There's clustering between these different pathways. And then if we kind of zoom in at the very kind of high resolution level, we really do see that there's, intron retention and genes involved in interferon signaling, which we know is correlated with CAR T resistance. And then FBXW7 has some exon skipping, and that's actually one of the gene that is ubiquitin ligase actually degrades MYC. And so again, a very direct kind of potential ability to influence, B-cell lymphoma physiology. So that, I want to thank everybody so much for allowing me to talk. The folks here, Austin, Nick's now faculty here. Austin is a senior resident trying to work in Ohio. He's been phenomenal, made a lot of this happen. And Fred and Locke have been our bone marrow transplant folks who really couldn't do this without. And so with that, I'll go ahead and stop and look forward to some great discussion.
Okay, thank you so much, Dr. Robinson. That was great. That was exactly what we wanted to show, that when it comes to radiation, it is not just to give treatment and kill the tumor. Radiation has, as you said, we thought that with the CAR T, the role of radiation is going to go down, but in fact, it opened a lot of opportunities for us. The issue right now that we have a lot on our plate to figure out, which first and foremost is to differentiate ourselves from solid tumors, because we operate in a completely different way. And the second thing is to figure out, should we treat everything? Should we treat with a high dose, with a low dose? How much should we think of the immunogenic cell death versus just saying that I'm going to think like a solid tumor and say, oh, the hypoxia is a big deal and I need to get rid of it. And we always have, the only thing I could take from solid tumors at this point is whenever we treated solid tumors, we produced lymphopenia. So this has to be also studied whenever we give radiation, and let our medical oncologists know that we do produce a lymphopenia just from the scattered dose that we give with radiation and from the circulating blood in that area. And that could affect them or affect the outcome without really knowing. So I'm going to go back, Timothy, to my question, which is, should we still talk about abscopal effect? Should we still talk as if we're talking about solid tumors? Isn't it a completely different model when it comes to hematological malignancies? And what is the role of low dose radiation?
Yeah, so I think that I completely agree with, I think the term abscopal effect is kind of misguiding us a bit. The ultimate goal, the thing that we're going to really be happy and pat ourselves in the back is not treating one little site of disease and having the other one respond. We want to make patients' outcomes be better. And so I would argue that the bigger kind of goal is really is how do we use combined radiation with existing immune therapies to improve outcomes. And so I think that's a better framework. So I agree with you. The abscopal effect is kind of this neat little thing that we've seen, but I reported, but in my mind, it's how do we make the patients do better? Two, in terms of kind of the physiology, I think it's a great question. How is this different? I think the fascinating thing is that I thought, hey, this is lymphoma. This is a systemic disease versus, solid tumors that are more localized. Yet we're still seeing that, in this setting, even in this diffuse disease that we thought we weren't systemic, we think we're actually having a benefit. So that to me says that I know we're all kind of, heme-centric, but I think the solid tumor folks should really be excited about this as well and be thinking about the same thing once they get effective CAR T for solid tumors. And then lastly, I would push back on the idea about the hypoxia in lymphomas. I mean, if nothing else, when you look at these patients, the PET scans, the SUV maxes are off the charts. It's one of the most highest uptake. You have necrotic tumors with the center. Something's going on there, and again, it could be acid, it could be hypoxia. But there's radiographic algorithms, radiomics, where they use PET signal to kind of determine hypoxia. So I don't know that I would count hypoxia out of these big angry tumors. I do think it's interesting that for a lot of these liquid tumors, I mean, that's not going to be hypoxic. But then also you've got the bone marrow stem cell niche, and where does hypoxia, play in that? So I wouldn't count hypoxia out of the picture altogether.
Mm-hmm. And then we have the very difficult situations where you have 10,000 lymph nodes spread all over the body. None of them is bigger than 3 centimeters. And then what do you do then? You're not going to suggest that you're going to give radiation to all of it. So what do you do in that particular scenario? Maybe there is
TBI,
no role.
TBI.
TBI, yeah.
I
Actually,
think
this
is a way between TBI and doing a more comprehensive radiation in the setting of CAR T cells. And we are actually running now a protocol that will test these hypotheses and trying to kill two birds in one stone, debulk and palliate, and at the same time, under the right circumstances, even more comprehensive limited radiation at the right time. So of course, this is all should be tested, and it's good actually that different centers have different models and different ways to look at it. I don't like the abscopal effect word, because it's just like what you see in the end. What we want to see, and we still trying to develop the tools to study it, is what it does in the context of the CAR T cells, and is there a way to measure the enhancement of the CAR T cell response with doing radiation in a variety of ways. So we think we are in the very beginning, many of us in this direction, and I think that in a couple of years, we will have the results, and it's a good thing that ILROG has this forum of all the CAR T cell interested radiation oncologists meet together, compare, talk, run ideas.
Yeah.
Can I make a quick comment?
Yeah, please.
So
Absolutely.
great talk, both Dr. Sauter, Dr. Robinson, loved it. This is really fantastic. The talks that you guys brought out made me think that we really need to be coordinating with our basic researchers. And I think the alternative splicing stuff is fantastic. And I, really rely on you to figure that out. But I think that we need to be thinking about how do we partner with our basic researchers. I finally, in the last year or so, been able to get one of our lab researchers, Andrea Facciabene, who you guys may know from the ILROG CAR T cell consortium calls, and he's starting to do some animal experiments, and we're starting to learn a little bit. And although everything's obviously too early, I think what we're learning supports actually what you're saying, Tim, which is I think we should just keep a very open mind because we don't know the answers. But it can't just be Dr. Facciabene and Carl DeSalm and Tim doing the basic research. We need to really partner with all the fantastic basic researchers and look at lymphoma specific models. So we can't just glom onto every solid tumor model. But Dana points out, yes, these heme malignancies are different. And so using heme specific mouse models, animal models, I think will be really critical. So we really have to kind of encourage our basic researchers to join us in what is really the cutting edge, I think, of immune radiation research. So with that, again, Tim, wonderful. I loved your philosophical slides. They were really very stimulating. So thank you.
Thank you so much. That was really awesome. And then another thing that I noticed over the past few months and few years, basically, that our medical oncologists are super interested in looking at radiation past just come and give it to the tumor. We have started at least 5 collaborations with our leukemia folks, myeloma folks, and lymphoma folks, just to examine what would be the role of radiation beyond just either bridging or managing a bulky disease or giving it in a palliative setting. So I would encourage all of you to keep collaborating and keep showing up to our CAR T cell consortium that has been very active, and we're going to activate it yet again because that is the future of transplant. Dr. Sauter, would you like to make final comments before we adjourn?
Just thanks for having me. And this is great. And what Tim presented, we're very familiar, and I'm good friends with Mike and Fred, and what's going on at Moffitt is really exciting. So I would just continue to encourage and emphasize, we are a very DMT, disease management team, heavy lymphoma service, and with Aki, and we can just learn a lot from each other. So the point regarding engaging basic scientists, this is always sort of the grail. So this was great.
Craig was an awesome talk. I wanted, as long as we have you here, what are your thoughts about the cytopenias? This is something that I've really wrestled with, and I think is a big kind of it's the interface between the radiation and the systemic therapy and the disease. What are your thoughts on, what do you think the drivers are? What's your philosophy on the cytopenias?
We think that because it seems to be the patients that have the higher degree of toxicity, i.e. cytokine release syndrome, it's probably cytokine mediated. I mean, early on, we had patients on study that I couldn't prove had a treatment-related MDS that we took to allogeneic transplant because they were transfusion dependent at 60, 90 days following CAR T cells. But now we're seeing it commonly, and it's reported in the literature. We believe it's outside these small doses of fludarabine and cyclophosphamide. It's likely mediated from some sort of activation factor with the CAR T cell.
Yeah, that's very interesting. And again, when we give patients radiation, they have fatigue, presumably that's the evil humors or some kind of cytokines. I think that's a very interesting point that we should think about kind of going forward.
All right. Thank you all. Thank you for our honorable guest speakers. Really was fantastic. 1 hour. We learned a lot, and I'm sure our folks learned a lot. Please, all of you, stay safe, and until our next webinar. Thank you so much.
Thank you.